So we've been doing work in terms of collaboration on patients who've had delirium in vascular surgery, and we were prompted to actually apply for a grant from the Peterborough Cardiac Innovation Fund, and we were able to then basically take a look at some of the clinical problems that we had with delirium. Lots of our patients were experiencing delirium, not having good outcomes, and obviously upsetting for family, staff, and the patient themselves. So delirium is a confusion that occurs fairly quickly, especially after a procedure such as vascular surgery or cardiac surgery, the other more common surgery as well as orthopedic surgery where you have high percentages of delirium. Patients are agitated, they're confused, they can sometimes get quite paranoid of the staff, they won't allow staff to intervene, put in lines. When lines are put in, they'll sometimes pull out the lines, they'll try to get out of bed, they can get injured, and staff can also get injured.
So first of all, sitter cost is if you need somebody to sit at the patient's bedside to redirect them, to prevent them from harming themselves, from getting out of bed, or from falling. So we often employ sitters, and what they do is really they watch the patient to try to make sure that they don't harm themselves in the post-operative period, and that they're more compliant. We can't have the confused, agitated patients walking around on the ward.
We found the highest rates of delirium in patients who've undergone lower limb amputation and open aortic surgery. The other predictive factors were if they'd had a previous delirium, they were more prone to have a delirium post-surgery, as well as patients who had a diagnosis of dementia.
Well, I think that patients with amputation have end-stage vascular disease. They tend to be a little bit older, so they have more cognitive impairment to start with. And, often amputation, it's a pretty traumatic thing. They're often in pain beforehand, so they may be getting narcotics, which may make the confusion post-op worse, and you have to give them pain control afterwards. And the combination of some dementia, the fact that they're in a strange environment, they've had surgery, and they have narcotics, can really contribute substantially to the delirium that they have.
So delirium is basically considered an acute situation, and lots of times you can actually treat delirium because there's an underlying organic cause to it, and people actually improve fairly quickly within a few days. However, some patients, the delirium can last and take a while to resolve, up to 6 months is quoted in the literature. And for some patients, they never return to their original baseline. So what happens is they start off at a higher baseline and they end up at a lower baseline. And that actually has huge implications for patient disposition. Sometimes they need supportive care, or they end up going to long-term care facilities like nursing homes.
Well, I think that the key thing is with the testing that we've done, we've been able to identify who are the highest risk groups. And so for those, there's a couple of recommendations. One, maybe we modify the procedure that the patient was going to have in order to put them at less risk for post-operative delirium. So that's the first thing. The second thing is we can educate their families that they're at higher risk, so the families can be prepared. And the third thing is we get Dr. Styra to look at their medications, because there's some medications that really potentiate the delirium. And we can eliminate those, and the sooner we eliminate those, hopefully we'll be able to then modulate the delirium that some of these patients face. So the title of our paper is The Impact of Preoperative Cognitive Impairment and the Type of Vascular Surgery on Postoperative Delirium and Cost Implications. And we really did this because of patient problems that we see. And we wanted to see if there's a way that we could prevent or modulate the delirium that we were seeing.
At UHN, the University Health Network, we work as an interdisciplinary team, which has really added to the care of the patient and has provided us as partners in care for our patients at the present time.
Cardiac surgery, vascular surgery, and cardiology, we have many multidisciplinary teams, and this is an example of the multidisciplinary care that we try to provide to our patients because we think it really enhances the value of the care that we can provide. So Dr. Styra is one of the valued members of our team. She comes and does psychiatric consultations within the Peter Mac Cardiac Center, specifically on cardiac surgery and vascular.